I'm going to lay out a case, and I want you to think about it a little bit before we start talking about the specifics of the Affordable Care Act. So a kid came in to see me last night with his tutu, and it was midnight or so, like I mentioned. I'd seen a couple patients at one of our rural hospitals on Big Island. I flew in this morning, and chief complaint was shredded weed up his nose, okay, which is not the biggest health problem that exists. And so, beautiful little boy, very upset about this shredded weed issue, and I don't even know what he was doing eating shredded weed at midnight or 11 p.m., but he came in and he had a pretty good wad of shredded weed up his left nostril, and he was in the ER for this, right? And I'm not trying to be critical, but all we really had to do was hold the other nostril and tickle him, and he snotted that shredded weed out, and he was good to go. And I wrote up my 5 pages of charts, and I'm sure they're going to get billed through the hospital, and it's going to be a $400 visit for this snot ball of shredded wheat. And when you think about the Affordable Care Act and all of the important parts that go into it, we also have to, what I'm saying is we have to think about what we as individuals are going to use our hospitals for and use our physicians for, and ask our nurse practitioners and our nurses to participate in, and what sacrifices we're all going to make this system work. I think that's going to be very important because we're going to constantly be reassessing this major transformation of the the healthcare system via the Affordable Care Act, and wondering, can we find the monies to provide healthcare for people with chronic and persistent mental illness? Can we find resources for people that have drug addiction, where we usually don't pay very well or provide much good service for drug addiction? Can we find the resources to hire the surgeons that we do need for big-time problems? It's really a big question. And so when I see a patient that just needs to be tickled and have their nostril held like that, I say to myself, my God, number one, I'm upset because I'm up out of bed again, right? As that's the stubborn doctor in me. But I also say to myself, we really are going to have to make some hard decisions. I'm not talking about death panels like Sarah Palin. The only thing I know about Sarah Palin and have in common with her is we have the same darn birthday, which my friends all torture me about every year. I also share the same birthday with Jeb Bush, so I'm really conflicted now. But, I think we have to be fair to the system and the process and really ask ourselves, can we afford these things? How can we convince each other to communicate with our organizations, with our groups? It's not just about stopping smoking, which is probably the most important thing we can do, and getting control of diabetes and obesity, because obviously you read in the paper today, 117% increase in diabetes in the last 15 years in Hawaii, which is not even the worst in the country. A lot of states were much worse, Alabama, Mississippi, I think. So we're going to have to do some smart things as a people, which again speaks to this idea of a common purpose to make it happen, but it is possible. We can have more health literacy. We can make good decisions about our hospitals, and we can keep in mind these good decisions pay for more psychologists. They pay for more home care visits. They pay for more admissions for people who are elderly when they really need them. They pay for more bypass surgeries when someone, God forbid, has a heart attack in their 40s or 50s. So let's keep that in mind. In Hawaii, we're in a unique spot. We have only 9% uninsured or so, which means that in some ways we are a little bit insulated from the larger impacts of the Affordable Care Act, but it still affects us in many ways profoundly. I see David, who's worked on these problems for years, and I think he might weigh in on that later too, but it's like it's a tenth of our population that for some reason haven't found their way into health insurance, and that's what a lot of this bill is going to do for us. We're hopeful. That's 120,000 people, more or less, and to give people perspective, and this is one of the big questions, what do you do when you add 10% of your population to the actual covered population? And you have to come up with more providers, whether it's doctors or nurse practitioners or PAs. That's something that we really do have to focus on. Again, for perspective, if it's 120,000 people, and that's a great oversimplification, because now we're talking about people getting more services and trying to do it right, but a physician should tend, if they're a primary care doc, should tend to take care of about 2,500 to 3,000 people in their panel. When I was in the clinic, because I was the only one down there, I had 8,000 patients, but most people didn't come. for years until they were very sick. So it varies a lot, but that would mean we need about 50 primary care physicians right away, and we only have one medical school, and we don't routinely have an easy time recruiting from other states. So it's another thing that's important for us to focus on and be mindful of when we go for solutions. Okay, so let's get to the Affordable Care Act. The Affordable Care Act, I'll reiterate the philosophy. The philosophy, as you all know, is basically get everybody covered. Get everyone covered. This might not have been everyone's approach. Some people wanted single payer. Other people wanted to model a totally private system where unfettered competition made it very inexpensive to get health insurance. I never bought that. That was not my belief. I agree. But what we got is this. So this is what we'll talk about today, which is to get, at least at this stage of healthcare reform, most people into the insurance coverage. And if we do that, it will have certain effects, and we can debate these effects for sure. But I have a feeling, I have a theory about what really is going on behind the Affordable Care Act, which I'm going to share. But the premise is to get 35 million additional people covered, and get them covered fairly well for primary care services. Move a lot of the resources that you've seen in that 1,000-page bill, a lot of resources into primary health care, whether it's community health centers. There's $11 billion now being spent additionally on the community health center system. I jotted down a couple details. Right now, 1 in 17 people is taken care of at a community health center or some clinic of the sort, like the one I worked in. And we have about 10,000 physicians, 6,000 nurse practitioners, and 11,000 nurses in that system. But the Affordable Care Act, part of the bill, probably on page 655, somewhere deep in that bill, was the intent to build over 120 new community health centers nationwide and get people primary care so that they could get care for things like urinary tract infections and early depression before it became severe, persistent depression, and they had problems with drug addiction as well, or other comorbidities, and to get people care for their bronchitis before they had scarring of their lung tissue and had chronic lung disease and ended up in the hospital all the time. So the idea is to get more monies into primary care, and I mentioned that example, that $11 billion example out of a multi-trillion-dollar bill, really, over 10 years, because that's the premise, really, to get all of that additional care to these people. Now, how do you do that? Because if it was easy, it would have happened in the last 30, 40 years, right? So it's not been easy. So it's really been a very staged process. We mentioned earlier that it all started in March of 2010, and here we are about 2.5 years later, and we've seen some implementation of it. We saw the bill pass, and we saw free preventive care in 2010. We saw small business get tax cuts to cover some people. We saw the exclusion on pre-existing conditions for children, and we saw that you could not keep kids off of people's insurance, families' insurance, if they were under age 26. That stuff is easy those are the easy things, right? Which is why, for political expediency, they did the easy stuff first. And we're building up to a climax here today because all the hard stuff comes in 2014. And so we're kind of here at the cusp of it. In 2011, they closed the donut hole. Everyone's familiar with the donut hole on Medicare, probably. And that was after you paid a grand or two, there was a large amount of money that anyone who's on Medicare would have to pay before their pharmaceuticals be covered again. Very difficult for people on a fixed income to pay that. And that's why it was so contentious, and that's also, I think, why they went to that in 2011. These are just kind of highlights. But also, they offered the free preventive care for seniors. Some people described that very negatively, as though we were priming seniors to have death panels and all this such nonsense. But it's not at all that. It's, once again, if seniors didn't have good oral health care, they had malnutrition. If they had malnutrition, they ended up in the hospital chronically. And if you end up in the hospital and you're a senior, it's $5,000 a day, one day after another. And then there's not a long-term care facility bed available, and you get stuck in the hospital, and Queens gets no reimbursement and they start losing money. And they end up having 50, 70, $100 million of red ink, and they can't sustain themselves. It's why HMC West closed, because it was very difficult for HMC West to get adequate reimbursement from the federal government for Medicaid and Medicare. And there weren't enough long-term care beds to help them with some of their challenges. So what happened here, far away from D.C., we actually lost a hospital temporarily. Very real impact that I believe could have been averted had we passed this bill, under Bush or Clinton or whomever. So it's something to think about anyway. So we move to 2012, the year that we're wrapping right now. And this is where it starts getting a little bit more technocratic in some ways. What I've seen so far in 2012, these are more of the trial balloons of what's going to actually help some of the economics of the healthcare system. Again, I think we're going to have a chance to speak more philosophically later today about what's really good for the people of the country and what might have been a better approach, but there has to be some savings, because in the United States we spend about 18% of our GDP on healthcare, right? Does anyone know what they spend in China on healthcare? Anyone have a guess? Lower. 2.5%. Not guess 10. I would have guessed 10. I was shocked to find it was just 2.5%. Now they're trying to actually, this is going to sound crazy, they're trying to increase their healthcare spend because they have a lot of chronic disease now. They have a lot of problems with environmental health issues in the countryside. How about India? 1.5% of their GDP, and it's a basic utter disaster in India as far as healthcare goes. I mean, nobody that doesn't have money can get healthcare, period, unless their entire clan comes and spends all of their resources to get Western healthcare. They won't get any. So India is actually seeking consultants right now. So if any of you are a consultant and speak any Hindi dialect, you should go there right away, because they're looking for a real change in their healthcare system to spend more money on healthcare and to develop more hospital systems that can somehow approach what even the United States had, but maybe more circa 60s or 70s, with a simple healthcare system that can get at least basic healthcare to people. So India and China, you can see, are very different than us, and we're going the other direction. We're trying to figure out ways to flatten the cost of healthcare, and I don't know if it's possible. We're going to see. We're going to really learn some lessons. The Affordable Care Act is probably going to be most important because it's going to teach us the real lessons about healthcare in our country. So, accountable care organizations. That's a big piece of 2012. What are accountable care organizations? Accountable care organizations are, we could speak for a day about this, but better to speak for a minute, I would say, about it. And the minute version on accountable care organizations is you have doctors partnering either with hospitals or with themselves. They take responsibility for, in this case, we speak about Medicare, but it could be for all different populations, private, Medicaid, Medicare. They agree to basically provide all of the care for that cohort of people, and if there's any savings year to year, then the savings themselves are shared back with the providers. And the idea is to reinvest in care coordinators, to do a much better job on prevention, and to get people the services that maybe they want rather than the services that they get prescribed or tested for or seen in the ER for and what have you. So that's what the premise of an accountable care organization is, and there have been a lot of grants from the federal government to do these things. Some of them are working, about half of them are showing savings and half of them are not showing savings. But we're going to know in the next year or two whether this approach, which in many people's minds just approaches what managed care was before, which didn't necessarily work, but it is something that's been big in 2012, and I think you're going to still see more of that. You might see a lot of that in partnership with hospitals. Keep in mind that about 2 out of every 3 healthcare dollars are spent in the hospital in the country. About 1 out of every 3 is somewhere in the outpatient setting. Probably should be flipped. We probably should be spending 2 out of 3 dollars on prevention and immunizations and making sure people don't get hepatitis and making sure children get, their all of their immunizations, if at all possible. Make sure that there's fluoride available for people. In Hawaii, I know we got controversy on that issue, but it's crazy. We should do it, for God's sake.